So we appreciate you being here for our symposium. This is our symposium on rehabilitation research using large data sets, issues and methods. And this is a symposium that's supported by our R24 infrastructure grant, which I'll tell you about in a minute. I just had a couple comments to kind of introduce the topic. So I think big data, everyone's aware of the attention that big data has received over the last several years. It's almost become a cliche. These are covered from two major scientific publications talking about big data, and this quote, that the march of quantification made possible by enormous sources of new data will sweep through academia, business, healthcare, and government. There is no area that is going to be untouched. And certainly those of us in academics and academia who have been doing outcomes research, and particularly we're focused because of our center and our research programs on rehabilitation and disability. And in some ways, this is a little bit of a new area for rehabilitation and disability investigators, because most rehabilitation investigators have clinical backgrounds, and when they learned how to do research, they learned how to do clinically based, patient-oriented research because we're clinical fields. So there are relatively, people are not necessarily trained in doing this kind of research. So there are obviously significant new opportunities that are developing, and we're going to hear about some of those today. A variety of different organizations and agencies have become interested in this and aware of the need for training and other activities associated with large data sets. And the NIH just recently, as I'm sure some of you are aware, started a new initiative called BD2K. And the BD2K initiative is Big Data to Knowledge. And they've actually created an office in the Office of the Director. They have a division or an office director that's promoting this program. And they're in the process of identifying, there was a group that did a working group that did a report to the director and came up with a number of recommendations, and out of those recommendations, this office was created, again, in the Office of the Director at the NIH. So that those recommendations are now being implemented, and as part of that, there are going to be opportunities, funding opportunities, and these are the primary areas that the working group at NIH identified. So facilitating broad use of data, analysis and methods and software, enhancing training in centers of excellence. Now, some of you are probably aware that they already had an RFA, a competition for grants for the centers of excellence. So I'm not quite sure where that's at. I think the grants have been reviewed. I don't know if the decisions have been made and any announcements, but we're particularly interested in the third point there, enhancing training, because that's what the purpose of our center is. The purpose of our center is to help build research capacity related to using large data sets in research involving disability recovery and rehabilitation. And as part of the mission of our center, and there's a couple of links there if you're interested in finding out more about the BD2K initiative at NIH. And I think there really are going to be some opportunities for investigators related to large data who are interested in analyzing and using large data sets. So again, as I just mentioned, the goal of our center is to build rehabilitation research capacity related to large data sets. So our center is an R24 grant, which is an infrastructure network grant. There's 7 of these grants that are funded by NIH around the country, from NICHD and the National Center for Medical Rehabilitation Research, and NINDS, the National Institute on Neurological Disorders and Stroke. And one of the components of these grants all have pilot project programs, they have visiting scholar programs, and we have some of our pilot project investigators here today and some of our visiting scholars here today as well. And this afternoon and tomorrow, we're going to be getting updates from them in separate sessions. So we also have an advisory board, and our advisory board members are joining us for the symposium and for the presentations this afternoon and tomorrow by our pilot project PIs. So this is part of our dissemination activities related to the center, and we're very happy that we have some just really high quality presentations for you this morning. I should mention that our center is a consortium. It involves the University of Texas Medical Branch here in Galveston, but it also includes folks from Cornell University, the Employment and Disability Institute, the Uniform Data System for Medical Rehabilitation, located at the State University of New York at Buffalo, and the Rehabilitation Institute of Chicago, and specifically the Center for Rehabilitation Outcomes at the Rehabilitation Institute of Chicago. And just real briefly, I'm going to introduce our speakers and our first speaker in a minute, but we have 3 speakers who are going to be talking about various aspects of large data sets, and they're going to be talking about them in a more general way, not specifically to rehabilitation, but again, our focus is trying to get this information out to a rehabilitation and disability-related audience. So, if there aren't any questions or comments, we're almost right on time. So, our first speaker this morning is Dr. Ann Deutsch. Dr. Deutsch is a clinical research scientist at the Rehabilitation Institute of Chicago and a research scientist at RTI International. She received her professional education and training in nursing from the University of Cincinnati and completed her master's and PhD degrees in epidemiology at the State University of New York at Buffalo. Dr. Deutsch is a certified rehabilitation registered nurse who has done innovative research at the intersection of post-acute care, Medicare policy, and healthcare quality. She was the first investigator to link Medicare claims files to rehabilitation outcomes data from the Uniform Data System for Medical Rehabilitation. This was before there was a CMS inpatient rehabilitation claims file. Dr. Deutsch published some of the earliest papers comparing rehabilitation outcomes across post-acute care settings. She was very involved in the development and testing of the Continuity Assessment Record and Evaluation, or the CARE tool, developed by CMS. In her current role with RTI, Dr. Deutsch is working on the development of national quality indicators for post-acute care with a focus on function as a quality indicator for inpatient medical rehabilitation. Today, she is going to speak to us about reporting guidelines for research using large database. This is a topic that has been identified as a priority area in the new NIH VD2K initiative. Please join me in welcoming Dr. Deutsch.
Great. So again, the title of my presentation is Proposed Reporting Guidelines for Research Using Large Data Sets. And the topic is part of the proposal that was put into this R24 that has been funded for. And the specific topics that I wanted to talk about as part of this presentation are: why are reporting guidelines needed? What is the impact of existing reporting guidelines? Third, why develop reporting guidelines for rehabilitation, specifically using large data sets? And what might be some of the proposed guidelines? I'll end talking a little bit about resources, and then would like to hear your comments, feedback, and suggestions for additional work in this area. So first of all, I want to define what are reporting guidelines. So a reporting guideline is basically a checklist, a flow diagram, or an explicit test to guide the authors in reporting specific type of research developed using explicit methodology. So some of the reporting guidelines you're probably very familiar with include CONSORT, which is for clinical trials. That's something that's been used quite widely and has been around for a long time. The guidelines have in common that they address issues in each of the areas where we write our summary of our research that was conducted. So they cover things like the title and the abstract, the introduction, the methods, the results, discussion, as well as other information. So again, I want to step back and talk about why this is important and why they're needed. So a published manuscript is really the only lasting product that comes out of research in many cases. And so that really is what's on record about the research study. So if the manuscript lacks details that are important, that will help understand the quality of the research, readers may not be critically assess the strengths and the limitations of the design, the conduct, and the analysis. Therefore, studies that lack these details are not replicable. They are not included in clinical practice guidelines. and they're not included in systematic reviews or meta-analyses. And so basically there's a lot of information that perhaps is known, but again, because it's not documented, it doesn't get passed along. And I think the title of this manuscript tells part of the story. So this group of researchers published this article in Journal of Trauma, and they originally planned to do a systematic review, but their title kind of tells you what happened. The title is Endovascular Repair Compared with Operative Repair of Traumatic Rupture of the Thoracic Aorta, a non-systematic review and a plea for traumatic-specific reporting guidelines. So again, they tried to do the systematic review, but as they reviewed the literature, they found so many articles lacked details, they were really unable to synthesize the data. Another quote I think that speaks to the importance and why these guidelines are very helpful is from Sir Ian Chalmers, who is at Oxford University, and his quote is, "Without accessible and usable reports, research cannot help patients and their clinicians." So again, if the record of the research really isn't telling the whole story, people won't pick up the information, and then ultimately it's not benefiting the people that it should be benefiting, patients and clinicians, and I would add on to that, this quote, policymakers. Doug Altman is one of the people who is leading the cause on making sure that research articles do provide as much detail as necessary to help readers, reviewers, editors make good judgments about the study, the quality of the study. And so he recently had a presentation in Chicago and presented a taxonomy of poor reporting. So he says that the problems in particular with research overall include incomplete reporting as a major problem, and in this case that means that key information is missing. He says that the information sometimes can be presented in a way that it's misleading. He also speaks to the fact that sometimes there's documentation that there's inconsistencies in a protocol that's being proposed, perhaps registered on clinicaltrials.gov, and then what actually gets published. Also, there may be some misleading interpretation of the findings. Sometimes there's non-reporting of studies, so studies that are reported on or registered with clinicaltrials.gov that aren't published many years later. And then sometimes there's selective reporting, either of the methods or selective reporting of the findings. There's a growing body of literature addressing some of these limitations in the literature. And so these are just some of the manuscripts that have recently been published looking at incomplete reporting. And so as you'll notice, 2 of the articles are from 2011 and 2 are from 2013. This is really an area where there's a lot of research being done and probably a lot more manuscripts coming out in the near future. So the first article talks about systematic reviews of the quality of research reporting in orthopedic journals. The second one looked at cross-sectional studies related to ecological studies. And for those of you who are epidemiologists or trained about ecologic studies, obviously there's lots of potential problems with those types of studies. And even in the studies that were focused on ecologic studies, they didn't identify that there was potential limitations to this study design approach. The article by Blakely talked about adherence to of randomized trials in terms of the consort reporting guidelines. And then also the last article talks about a comparison of the content of randomized controlled trial reports and trial registry entries. Some of the reporting guidelines that you're probably most familiar with, again, the consort, which has been updated several times, the Strobe statement, which focuses on the reporting of observational studies in epidemiology, the PRISMA statement, which is about preferred reporting items for systematic reviews and meta-analyses, and then the Squire project, which is focused on quality improvement projects that are used for research. So one of the areas of literature that you'll find focused on reporting guidelines, sometimes you'll see editorials where people are very complimentary of the reporting guideline effort and feel that it's a good thing. And others sometimes feel that there are some potential limitations of having reporting guidelines. So some of the feedback, more negative feedback, is about concern that people are pushing certain ways of doing things onto the authors. Also, there's concerns that if there's a requirement to complete guidelines, let's say a journal would decide that reviewers should use these checklists, these reporting guidelines, as they're reviewing articles, there's a concern that the reviewers might say, oh, I don't have time, I'm not going to bother doing a review because it's too much effort to have to, read the article and then go through this checklist that, I don't think is terribly great, perhaps. And so, again, some positive enthusiasm, but also some concern about potential unintended consequences. So one area of research that's also developing in this area is looking at the impact of these reporting guidelines. So a recent study by Kobo examined the effect of having the existing review process complemented by having additional reviewers look at manuscripts that were submitted and use the reporting guidelines as part of the process. So basically, the review process happened as is, plus then there was these extra reviewers, and the extra reviewers were focused on using the checklist. So what they found in this study was that the additional reviews based on the reporting guidelines did improve the quality of manuscripts, but the effect was smaller than what was hypothesized by the authors, and they said that it was not definitively demonstrated. They speculated that authors adhere more to suggestions from conventional reviewers than the extra reviewers who had been added on who had these checklists. And part of what they thought was going on was that sometimes so let's say, the checklist said, make sure you address the handling of missing data. So perhaps the authors realized maybe they hadn't done as much as they could have, and so they didn't really address the comment because they really, in their methodology, had not perhaps paid attention to that as much as perhaps they might have. And so what Kobo and his collaborators felt that authors should be aware of the future requirements of reporting guidelines at the very beginning of their studies so that they're able to implement issues, let's say, related to missing data. So part of one of the struggles I think that I and other people have with these reporting guidelines is they're really, really just focused on good reporting of the data. They're not meant to influence the design or the conduct of the study. They're really, again, very, very focused on, is the study as it was done reported clearly so that we can make a judgment about the quality of the research. So as Ken mentioned at the beginning, there's this growing body of large data sets out in the world with health-related information. And they're increasingly used by research. In rehabilitation specifically, two databases that are used very widely are the Model System Database, and Cindy Harrison Felix is here in person and is with the Statistical Center for the Brain Injury Model System group. And so again, a large database. If you're not familiar with them, these are basically research data sets for patients with spinal cord injury and brain injury and burns. The work is funded by the Department of Education, the National Institute on Disability and Rehabilitation Research. And basically patients are recruited while they're inpatients in the rehabilitation centers, which include both inpatient rehab facilities and long-term care hospitals. And those patients with the diagnoses of, again, spinal cord injury, brain injury, and burns are followed over time. The spinal cord injury database, which is based right now at the University of Alabama, Birmingham, is a very large database. The data collection started in that in 1973 or so, and patients have been followed for more than 40 years. So patients are recruited during their inpatient rehabilitation or LTAC stay, and then they are followed up at 1 year and then every 5 years after that. The items in those data sets obviously have changed over time and probably will continue to evolve. There's also special modules that are added on at different cycles, and so there's additional data, let's say focused on, let's say, assistive technology for a 5-year cycle of the grants that are provided as part of that work. But those are very, very rich databases, and I have delved into the spinal cord model system database quite a bit and starting to get into the brain injury model data set. So the data typically collected for the administrative and clinical purposes is part of, again, what's in these databases, but obviously when these databases are collected, there's not a priority research questions. And so the data cover claims, assessment data. So for those of us in the rehabilitation area of research, the inpatient rehab facility data set is a large data set that's used, and the FIM instrument is obviously the functional assessment instrument included there. Other assessment data sets included the minimum data set. The OASIS is the data set used in home health agencies. There are also a growing number of disease and product registries as part of quality reporting programs that are being implemented, and obviously more and more hospitals and healthcare entities are collecting data electronically, and so we have a large number of data available through electronic medical records. So growth in this area has generated increased interest in methodologic issues related to large database research. As Ken mentioned, few rehabilitation researchers are actually taught how to work with these databases, and so a lot of the grant is focused on training, and we'll be hearing about a lot of the things that people have learned and the experiences that people have had working with the large data sets this afternoon and tomorrow. But in addition to developing the skills and experience, the grant also included this opportunity to develop reporting guidelines specifically addressing rehabilitation, research, and large data sets. And so that is actually what I'm going to focus on for most of my presentation. I have been thinking about doing this for a very, very long time, and so when Ken approached me about being involved in this grant proposal many years ago, I had suggested to him this might be an area of research, and I was very fortunate and appreciative that Ken found that this would be an interesting thing. So I obviously have learned from my own experiences, my own mistakes. I also do a lot of manuscript reviews and pay a lot of attention. What did I like about this? What didn't I like? Obviously, I get feedback from the people who review my manuscripts that I find helpful and think, oh, you know. So a lot of the issues that I'll be talking about today as part of potential reporting guidelines for large database research and rehabilitation are not necessarily based on literature, but they're things that I just have had from personal experience with, again, just my own research, but also I get to work with medical residents at my position with Rehab Institute of Chicago, so I've done some mentoring of medical residents, and that has been a valuable lesson for me. I sometimes send the medical residents out to the literature and say, oh, well, why don't you see how people typically report FIM scores? You know, what are the different options of aggregating that data up and reporting it in manuscripts? And sometimes they'll come back and say, well, it's really hard to know what to say about the literature, because some people do it this way and some people do it that way, but then sometimes it's missing other pieces. So I've learned a lot from that. I've also been a mentor in this R24, and so I've had the opportunity to work with some great people who have also shared some ideas with me. And so a lot of what I'll be presenting are things that, again, are personal experiences. And then also I've reviewed a lot of the existing reporting guidelines, those that are kind of formal from the Consort group, Doug Altman's group, the Equator group, as well as other articles that are in the literature focused on large databases specifically. So the reporting guidelines are, again, addressing the areas that are typically covered in writing a manuscript, and I will be presenting mainly methods as the largest area, because that's really where I see a lot of the issues in large databases. And I'm actually going to save the title and abstract for last, and I'll tell you why when I get there. So we're going to actually talk through the introduction piece first. And again, a lot of the reporting guidelines cover the basics about, make sure you do this well, and it's kind of basic research 101. And so the purpose of what I'm presenting today is what additional issues are specific to large databases, and what are some specific issues to rehabilitation in particular, or post-acute care in some cases. So in the introduction, I think that the only thing I wanted to highlight was, or a couple of things I wanted to highlight, was that when somebody is doing research with a large database, it's really important, in addition to describing the importance of the study, explain why the data set was used and was appropriately suited for the study. Research questions should not be selected and tailored to fit the data set. Again, from my personal experience, sometimes I'll be mentoring somebody and they'll say, oh, well, tell me, about the data set, and I'll figure out a question from it. And so I think it's always important to think through what you're interested in and then figure out what data set really works to answer that question. So the questions need to be important in and of their own right. Sometimes I find people who say, well, I've got to do a research project. Can you help me come up with something? And what data do you have? Another, so actually related to that, I wanted to highlight, I found an article that actually has its own checklist of the match between the research project, the research question, and the database. So again, a checklist for a checklist in this case. Another topic I think that is important in the introduction is describing the pre-specified hypotheses or research questions and identifying any theories or other means that were used to derive the hypotheses. Dr. Graham and I presented a couple years ago in Chicago at an arthritis conference, and we were talking about large databases and the potential for the data being used for studying rheumatology issues. And one of the physicians at the end of our presentation put up his hand and said, do you have hypotheses, or are you just data mining? So I think it's really important that people understand this is science, and that there are a priori hypotheses or research questions. And I think if it's not in the article, people won't know that. So it's really important to make that statement. Here's an article that I wanted to highlight just in terms of this issue about the match between the database or data set and the research question. So I work on the model system project out of the Rehab Institute of Chicago, the Midwest Regional Spinal Cord Injury Model System. And one of the things that has been noted in the literature is that there's a growing number of elderly people in European countries in Canada, number of elderly, the incidence of spinal cord injury, traumatic spinal cord injury due to falls has increased in Canada and in European countries. And so I also noticed that in the model system database, the average age of patients in the model system databases for spinal cord injury had been going up. And so as part of one of our research projects, I specifically posed a research question asking whether the incidence of traumatic spinal cord injury among the aged elderly increased and over time. And so obviously the Medicare databases is a great resource for that. This project has its own challenges that I'll come back to a little bit later, but I used the Medicare claims data and the inpatient rehab facility patient assessment instrument, the IRF-PI. So I had both demographic characteristics, I had costs, I had functional status on admission and discharge, and had basically follow-up data as part of that. The challenges were defining the population of interest, that is traumatic spinal cord injury. And again, I'll spend a little bit more time on that later on. So again, with the introduction, I think there's a lot of basic things that are covered in textbooks and a lot of the other reporting guidelines. So I don't really think there's too many things that are specific to large databases that I think deserve attention. The area that I think could really use a lot of attention is in methods. So I have quite a few slides focused on methodology issues, and also some examples of some of my work and some other work from the literature that address these issues. So oftentimes, you might think this is pretty basic, but people will sometimes publish articles and say, well, I did an analysis of a large data set, or I did secondary data analysis, but then they don't identify the study design that they used. And so secondary data is just kind of a technique. It doesn't necessarily tell you the type of data, the study design. So, is it cross-sectional? Is it a cohort study? And those obviously are important details. And some of that obviously will be evident as you read through the article, but I think it is important to report the actual study design in the methodology section. Sometimes people will use epidemiology terms, sometimes people will use other terminology, econometric, and I know sometimes that can be a little bit confusing, but there's actually a couple of great articles that our next speaker has published, Dr. Herbert, about crosswalk between the different discipline terminology for study designs. Another issue that I think is important is that any large database study should report or describe the data set purpose. So is it Medicare claims data for, or claims data from an insurance company? And so there's specific strengths and limitations to claims data. And so I think that's really important to understand so that it can help people understand, again, the strengths and the limitations of the study. Is it a research project that is just being used for another purpose or to address additional research questions? Is it a patient registry or a product registry? Also, I think it's important to describe the organizations that contributed to the data set. I mentioned the spinal cord injury and brain injury model system data earlier, and I've done quite a bit of research, as I said, on the spinal cord injury model system data set, and I wrote up a manuscript related to this, and when it was submitted, one of the peer reviewers, one of their feedback was, well, you don't have to explain who the model system centers are. You said there's only 14, you said that they're, these more kind of academic medical centers, but, everybody knows that. And so they didn't think it was useful to report. But with more and more people looking at literature who maybe are not familiar with these data sets, that would be a really important thing for people to know. And that is indeed a very select group of data centers that submit data to the model system data centers. So right now for the spinal cord injury model system centers, there's only 14 centers around the country that submit data. And one of the criteria for this particular the people who are in that data set are people who got successfully competed for grants for a grant offering from the Department of Education. And one of the criteria is that these entities have to have at least 30 patients per year with a spinal cord injury. So by definition, they're kind of the high volume centers, and they're also the centers that are often affiliated and have researchers and often are affiliated with universities. And so again, a very select group, and so that really speaks to the generalizability of any findings. So very important, I think. Also, I think it's important to identify clearly the target population. I know some of the articles that I have reviewed in some of the rehab journals recently, and also some of the papers that I have reviewed. Sometimes people have gotten these large data sets, for example, Medicare data, MedPAR claims data, or the IRFPI data, and they probably, when they requested the data from the Medicare program, had a very broad research goal, and so they're publishing, let's say, one topic related to one group of patients, let's say patients with stroke, and then they report the total number of records that they got from the Medicare program. So they got 11 million MedPAR files, but then they're really only focused on this very small set of patients, and so sometimes it's a little bit I think cleaner to identify the target population, and we will talk about diagnoses in just a sec. So really starting with the inclusion criteria and then talking about the exclusion criteria, and sometimes I think people kind of don't quite step into it that way. One of the areas that I think I really am focused on a lot right now and particularly interested in is diagnosis identification. So a lot of the studies in rehabilitation research using large data sets have focused on one particular diagnosis. So patients who are recovering from hip fracture, patients recovering from stroke, or perhaps a hip replacement or debility. And so we're quite fortunate in the rehab industry. There are several ways that these patients can be identified in the data sets. So in particular on the inpatient rehab facility patient assessment instrument, there are impairment group codes that tell the primary reason that the patient was admitted for rehabilitation. There's also etiologic diagnoses that are reported on the IRFPI, and there's also obviously claims data that can be linked with those data. And so one thing that I think is really important is to identify the specific method used for selection of patients with diagnosis. So if a patient, or if a study is about patients with stroke, then was the impairment group used as the criteria, or were ICD-9 codes, or a combination of the two? And I think it's important to recognize there are limitations to whatever process is used. And I wanted to highlight in particular at this point that in a lot of the literature in other areas, there are many, many studies looking at the validity and different ways, different algorithms that can be used to identify patients with condition XYZ. So for example, asthma, or another type of diagnosis. So again, that's not something that you commonly see in the rehabilitation research, and I think it's an area that could be improved. And I'll have some examples from my own work in next couple of slides. I think another area that is related to this is that it's important to specify whether the assignment of the diagnosis occurs at the acute care setting or the post-acute care setting. And this is something that I think I've become particularly more sensitive about given all the interest in the bundling healthcare reform talk, because people often in a bundling approach will go back to the acute care diagnosis and say that is the person's diagnosis. And so when I look at some of the research and some of the analyses that I'm involved in, I see often people are assigned a diagnosis of, let's say, urinary tract infection or fever of unknown origin as their rehabilitation problem. And that probably is not the case. And so my typical example when I work with my economists are things like, okay, well, maybe the person got admitted for this fever of unknown origin, but then they had an iatrogenic stroke, and so what they're being admitted to the post-acute care rehabilitation setting is for the stroke. And so if they get classified as fever of unknown origin, which is going to be miscellaneous, right? Because it's such a weird diagnosis for rehabilitation, it really causes some misclassification problems. And so again, where is the source? One of the challenges, of course, with using a post-acute care diagnosis, which is what I prefer to use, one of the challenges is that coders are taught to basically code what are the reasons that the patients are being admitted to this particular setting. And so it's not the stroke that the patient is being admitted for, but let's say the consequences of the stroke. And so there are these wonderful diagnoses like gait disturbance, difficulty with ambulation, aphasia, hemiparesis, and that really doesn't tell us how to classify that person. Hemiparesis might be from a stroke, but it also may be the consequence of a brain injury. So this is an area that I think is really, really important. And again, my particular interest in this is growing probably every week because I'm involved in some of the payment reform and some of the quality measurement work, and it's so important to understand the primary diagnosis. The recovery for somebody, if you're looking at functional status, the recovery trajectory for somebody who has a neurologic problem versus somebody who has some kind of more medical surgical debility type issue is quite different. And so misclassification in that case is really, really important to understand and consider. And I'm very aware that a lot of the work that's being done related to quality measures now is having an impact on finances for hospitals. So I really do feel it's so important to try and get that methodology straight. So I just, as an example, wanted to highlight the IRF-PI data. And so, as I mentioned before, there is a, on the IRF-PI, there is an impairment group code. So people, often it's clinicians, are reporting that this person had a stroke or they had a hip fracture or a hip replacement. And then to help guide people to assign patients to the right impairment group, there is in Appendix B of the IRF-PI manual a list of ICD-9 codes that are commonly seen with patients with these different impairment groups. A lot of times when I talk to people, policymakers or health researchers who are not necessarily rehabilitation researchers, they'll say, oh, well, you know, there's this list, and so the ICD-9 code is really what assigns people to their payment groups or to the impairment group code. But there's actually not a perfect relationship between these two. Basically, this is really an unlooked at area that I think has a lot of interesting information. And so what I did for this particular analysis was I looked at among the people who are categorized as debility, traumatic spinal cord injury, non-traumatic brain dysfunction, non-traumatic spinal cord dysfunction, hip replacement, stroke. When patients were assigned those impairment group codes on the IRF-PI, how often did the etiologic diagnosis that was assigned to that person for the same stay, how often was that actually on that list at the back of the IRF-PI manual in Appendix B? And so debility is very, very low. So it was basically fewer than, about 15% across the many years of data that I looked at. Fewer than 15% actually had an etiologic diagnosis that was a debility code. On the other end of things, stroke, when a patient was assigned an impairment group code of stroke, 95% of the time, the etiologic diagnosis did match with that impairment group. So probably stroke, even if you had different selection criteria, if you selected patients based on ICD-9 codes versus the impairment group code, you'd probably find similar findings. But in terms of debility, you'd probably find very different findings. So I think that's, again, an area that's really important to report. As part of this work, I've also looked at when people did not get the etiologic diagnosis that's on the list, what did they have? And is this a case of misclassification, or is this a case that maybe Appendix B can be updated because there's a missing etiologic diagnosis? So actually etiologic or iatrogenic stroke is a great example of probably something that should be added to the Appendix B for stroke. There are definitely some things that I've learned as part of this work in checking with some of the physicians who I work with at the Rehab Institute of Chicago. Some of the diagnoses that are listed as etiologic diagnosis on IRF-PI an Appendix B are actually not assigned to the right impairment groups. There's for example, one code under stroke that really should be classified as traumatic brain injury. And what I find when I look at the data and say, okay, among the people who have that particular etiologic diagnosis, what impairment group codes are being given, and there actually is a mix. In some facilities, in some records, patients are assigned stroke, so they're following what's in the manual, and then in other cases, clinicians must not be looking at Appendix B and they're coding the appropriate code of traumatic brain injury. So again, I think some work can be done there, and this is, again, directly helpful, I think, to policymakers as they consider payment issues, and payment is often tied to diagnosis as one of the predictors of payment, and then also quality measures. Just want to also highlight sometimes the relationship between the etiologic diagnosis and the impairment group code can change. And so this is just a study that I did as part of a Switzer Fellowship funded by the Department of Education. I looked at the percent of patients who had a hip fracture as an etiologic diagnosis but were coded hip replacement as their impairment group code, and that's actually not correct. If a patient is admitted to an inpatient rehab facility and they have had a hip fracture, they should be in the hip fracture impairment group code, but sometimes these patients have a hip replacement, and so by mistake sometimes people use to code that the person had a hip replacement. So both are true, but there's an algorithm that clinicians are supposed to follow. And the reason that I think this is particularly interesting is that it speaks to the how money or policy shape behaviors. So I actually have looked at this for many, many years. I think like when I first looked at it in, kind of early 1990s, it was like 10% of the patients who were coded as hip replacement had had a hip fracture according to their etiologic diagnosis. And over time it's gone down, and in particular you'll see that it has gone down a lot when PPS was implemented. And that's because, if you go to the next slide, what I show here is that if you assign somebody joint replacement instead of hip fracture, pretty much you lose money on each patient. And the amount of money you lose can be up to $6,000 per patient. So this is, I just created standardized payments. It's not adjusted for teaching, but it's, a general. But if you admit a lot of patients with hip replacement under the IRF PPS, you'd be losing a lot of money by making this simple diagnostic area. So it's actually interesting that basically, as I've looked more recently at data, people don't make that mistake anymore. Word got out that you're losing money if you don't correct it. And so my point here is that those of us who are doing research with these databases should recognize that sometimes there's these incentives that make people change their behaviors. Here's actually another example where again, sometimes people are coded non-traumatic brain dysfunction instead of stroke. And in this case, sometimes the loss is $9,800 per patient, but you can also actually come out ahead by $5,000 in some cases. So what I've looked at in the data for the same time period, this error continued to be a problem under PPS. People didn't correct this one. There wasn't just this clear impact, and so the word didn't get out, or people didn't develop software to help cue people that they might be making coding errors. So next area I wanted to cover was about describing exclusion criteria and rationale for these criteria. And again, this is just something that I've kind of learned through my experiences. I was working with somebody, and they had set out an exclusion criteria for a study and wrote it up, and I said, oh, how did you end up choosing these exclusion criteria? And I kid you not, they said, well, Ken Ottenbacher used these exclusion criteria, and he's this great researcher, so I just did what he did. And I said, yeah, but you've got a different research question than him, so you really should be thinking about whether that really makes sense. So I think sometimes we look to some of the great researchers, role models, and then we kind of think, well, okay, they know what they're doing, so I'll just copy what they're doing. But again, really, really important to think about what's your research question and how does it make sense. And perhaps it does. Incomplete stays are very commonly exclusion criteria in a lot of studies that I do, and I know some of the studies that Ken does. Another issue is in describing the time frame of data, indicate whether patients are admitted or discharged during the time frame. So just as an FYI, Medicare, when they send out the IRFPI data, they'll say, okay, this is data from 2012. That's based on the discharge date. I think the skilled nursing facility data, when I got I think it was the MedPower skilled nursing, that data are actually cut out based on admission date, because people don't always necessarily have a strict discharge date. So there's a bit of a disconnect. And this may be a little bit picky, but I will tell you with some of the quality measures work that I'm doing, some of these things are just so important to pay attention to. Who's in a measure, who's not in a measure, and this all needs to be so transparent because, again, it can affect payment. So these kinds of things I think are also important for research. In describing the variables, I think it's really important to not only describe the actual items, data elements, but also the time points. Was the data the admission or during the stay or discharge? And again, I might really have a different reaction if somebody does a study and they adjust for falls. And let's say, it's comparing inpatient rehab facility patient outcomes and skilled nursing facility patient outcomes, and we're just looking at, let's say, function, discharge to community, and if the person is adjusting for falls that happened prior to admission, I'm really happy. I think that's very appropriate. But if they are adjusting for falls that happened during the stay, I would not be so happy with that. And in part, that's because if you are adjusting for something that happens along the causal pathway, yes, indeed, both the falls before the admission and during the stay are related to outcome, but the fall during the stay might actually reflect poor care in the facility, and therefore you don't want to adjust away or give them credit for that, because then again you're masking for that person who did have the fall during the stay, you're masking what happened in that instance. Also, when we often have lots of data to work with, so, bladder incontinence can be, 5 or 6 different categories. How incontinent was the person? On the care tool, for example, we have people are continent, they have stress incontinence, they have daily incontinence, they have incontinence every time. And so how you actually take that raw data and aggregate it up is really important. Is stress incontinence categorized as continent, or is stress incontinence categorized with daily incontinence? That's really, really important. And one of the things that I was very fortunate to be involved in the post-acute care payment reform demonstration, do a lot of the training at post-acute care facilities, and one of the things I learned was that home health nurses are really, really great at getting out stress incontinence. The other post-acute care settings are not as good as documenting that. And so, again, if I was comparing outcomes in home health versus, let's say, skilled nursing or inpatient rehab facilities, the way I categorize that would really be really important, because again, it might vary by setting. The scales used in the study, oftentimes people report, well, we use the FIM, and the FIM has been shown to be reliable and valid. And so one of the things that I think is helpful is to actually do a simple reliability check with your current data. So if somebody says, well, I'm not sure if those people got trained on the FIM, so I'm questioning your results, if you're able to do a quick internal consistency analysis, report a Cronbach alpha on your own data, I think that's really great to add to the study. And again, pretty quick thing, right, Denise? You did that as part of our work together. Comorbidities, another area that I think really important. A lot of people will use the Charleston, and sometimes I will ask people, why did you choose Charleston? Oh, well, it's the one that's kind of out there. And then I say, well, do you know that that's actually meant to predict mortality? That was why I felt, oh, I didn't, okay. Well, but what else is out there? And so I think knowing a little bit more about why something was selected should be specified. Also, in some research, people look back to acute care data for comorbidity. Sometimes they don't. So I think that's really important to specify what is the source of the comorbidity data. Did you feel that maybe the inpatient rehab facility data or perhaps a skilled nursing facility data that wasn't reported completely on the MDS or in SNFs claims, and so you went back to acute care? That's commonly done in policy studies. I can't emphasize data cleaning enough. I think probably some people think I obsess about this, and I am very happy. Actually, somebody wrote a whole book about it recently. I think not many people get excited about that, but I think it's so important to spend the time. I used to think, well, everybody knows to do that, but more recently in some of the work that I've done, I find people skip over this, and it's really problematic. I think there's an expectation that if the data comes from Medicare or the VA, it must be perfect, so it doesn't need data cleaning. That's not the case, obviously. And even though there might be some basic data cleaning, your research study may not actually, you may have additional cleaning issues that you provide even in a clean data set. One of the things, when I work with residents, I will often say, okay, if you want to work with this data, you're going to have to do cleaning. I've already cleaned it, but I'm going to give you the unclean file. And so I've gotten interesting reactions from that, but I think it's an important process. If you don't know the data, you shouldn't probably be analyzing it and interpreting it. And the only way to get to know your data is to kind of play with it a lot and really get to know it. There are duplicate records. Sometimes when the data comes from Medicare, there are outliers, there's errors. I know when I did some of my dissertation work, I linked up data from the UDS and the MedCard data, and I had one mismatch of age where Medicare said the person was 140 years old, and in the other database the person was 40, so I scratched my head, yeah, I don't think 140, and 3 hours of therapy rehab, yeah, I don't, that sounds like torture even if it's possible. But errors happen, and so again, catching things, and again, I would not have expected that, but it does happen. I also had people who have a height of like 5 inches, where, yeah, it's probably 5 feet. Report the frequency or the percent of missing data and the handling of missing data, imputation. When databases are linked, I think it's really important to talk about whether there was a unique identifier or there was a deterministic approach, or is it perhaps a probabilistic approach, which is actually what I did for my dissertation. Talk about the variables that were used for matching and the success rate. I think that's all important. Here's my book. See, I'm pretty obsessed with this. But it's actually really a great book for those of you who are interested in it. There's also, I have about 4 or 5 books that have great chapters. The Tabachnik book, some of you may be familiar, also has a whole chapter cleaning up your act, which I think is fabulous. Another area in terms of methods is when people are followed over time, reporting loss to follow-up. Also, I think it's important to report the unit of analysis. Are you looking at patients or are you looking at stays? I think those of us who have worked with these large databases don't always remember that perhaps the patients can be in multiple times. In fact, in the spinal cord injury study that I mentioned earlier, I had cases where the patient had 5 different stays in one, brief time period. They just bounced back and forth between acute care and inpatient rehab. And as you'll see in just a few minutes with some of the analyses that I've done looking at program interruptions, this really can impact things like length of stay reports, and so it's really, really important. The other thing to highlight is the model system databases that I mentioned before. They look at the entire kind of episode of post-acute care. And again, the Medicare claims data, the IRF-PI assessment data, that's based on what Medicare defines as a stay based on payment issues. And so I've done several studies where I kind of link up those databases, and there's real differences. You have to really match up the stays in order to make fair comparisons of those data. So just again, a quick example of work that I did as part of my Switzer Fellowship. So in 2002, Medicare implemented a prospective payment system for rehab hospitals. They also made modifications to the IRF-PI at the same time. One of the changes that they did was they changed the program interruption definition. So that's when somebody starts their rehabilitation program in the inpatient rehab facility, but then bounce back to acute care and then come back to the same inpatient rehab facility to wrap up their care. And so they changed that program interruption length from 30 days to 3 days. So comparisons of the IRF data prior to and after PPS are really important to pay attention to this change. So just as a kind of visual display of this, in the old days, if somebody had a 10-day IRF stay, then they went to acute care for 10 days, and then they went back to the IRF for 10 days. I did 10 days for easy math. You know, their total length of stay for the rehab facility is 20 days over a 30-day period, and that's one stay, that's one record in the FIM IRF data set. After PPS, basically those two records got separated as two different stays, and so now the average length of stay for in the second database is 10. So basically it got split in half. So again, pretty important to make a difference because that does happen a fair bit in rehab. So this is what I did as part of this work. I looked at what the unadjusted data would look like for the number of patients. So this impacts the number of cases, basically, who received inpatient care. It impacts community discharge. You can see it looks like the prior to PPS in 2002, 73% were being discharged to community, and then all of a sudden it dropped to 70%, 69%. Program interruptions look like they dropped dramatically in these unadjusted data. Discharge to acute looks like they jumped a lot. But when you look at the adjusted data, it's actually not as serious. And in fact, I've got a graphic that basically shows this is the unadjusted data, but when I basically recoded the data so that they were equivalent, I adjusted it to the PPS approach. It's certainly not as bad. So that was the, let's see. So this is the discharge to community. Again, this is, patients. Program interruption, thank you. So that really changed a lot too. So again, just knowing your data and knowing changes to the data set is really important. Studies that examine trends over time really need to consider that facilities enter and exit the market. And so one of the studies that I did, I basically used the same store approach. And so I had only the facilities that were in the time frame of my study, the entire period. So, I lost a lot of facilities, but I also feel like changes that I spoke to in terms of the patient characteristics at the beginning and end of my study really reflected what was going on. Individuals who enter and exit the insurance plan is another thing. So I'm currently helping CMS with some of the work on readmissions related to post-acute care, post-IRF discharge, post-LTAC readmission rates. And so it's really important, obviously, to pay attention. Is that person still a Medicare fee-for-service beneficiary? Or maybe, they switched over to managed care, so it doesn't look like they got readmitted, but in fact they did. And so again, keeping your time frame completely clear in terms of whether patients were eligible for readmission or not in that particular analysis. Historical events, really important to take into consideration. They are both strengths of what we do and limitations. In studies that compare case mix, adjust for the case mix factors, and describe the rationale for the role for each variable. And one of the big things that I always come across is length of stay. And so I don't think if you're trying to compare two different treatment approaches and look at the outcomes of patients, I think length of stay is part of that treatment. And so I don't think you should adjust for that. But oftentimes when I've submitted papers, reviewers will come back and say, adjust for length of stay. And from my perspective, I think you're changing a research question if you adjust for length of stay. Regression diagnostics obviously should be reported. Functional status, I can't tell you how many articles I read and people say, I've got FIM scores, but they don't tell you which FIM items they included. Sometimes you'll find studies that have 12, 13, or 18 items, and sometimes I'll just have to look at the results and say, okay, they got up to 120 as their discharge scores, or 126, and they had 120 on admission. They must have included all 18 items. But I think it's really important to make that clear. Activity did not occur is a missing code on the IRF-PI. It's actually coded as 0, but sometimes people don't realize that means missing data. So there was recently a government report that was put out, and they just treated that like it was actually below level 1. And unfortunately, that's 0 code. Activity does not occur is only available on admission. So for people who did not perform an activity at discharge, for example, going up and down 12 stairs, not often done even at discharge in inpatient rehab facilities, it's not equivalent. So there's some mismeasurement there. People often use Roche analysis, and so there's specific guidelines on how to report that on the website of the Journal of Applied Measurements. I think that would be important to follow those guidelines. Increasingly, I think studies are starting to look at costs, and I find in the rehabilitation literature people will talk about costs, but they won't specify if that's actually what Medicare paid, what the facility got, if it was what the patient liability was, and those are all different perspectives, obviously, and nobody actually really knows how much it costs, but it's really important to know what they are. And sometimes you'll see people report charges or mix up charges and payments, and those are really, really different and really important to say what it is, again, so that these data can be aggregated as part of meta-analyses or systematic reviews. For those who are interested in doing economic analyses, there's actually a set of guidelines for you called the CHEERS. For analytic studies, obviously we have in large database studies huge issues with case mix differences, potential confounding, sample size selection, and so our next speaker actually will be talking about instrumental variables, but there's obviously lots of information that should be reported in terms of the details of whatever approach was used to address these potential validity threats. In the results section, I think it's really important to report the facility characteristics. So as I mentioned, the model system databases, they're not all average facilities. They are specialized facilities. Also, some of them are inpatient rehab facilities and some of them are long-term care hospitals. And so they work under different Medicare rules. So that's really important, and people just generally refer to them as rehab facilities or rehab centers. But again, there may be important differences. Somebody was looking at the impact of the IRF prospective payment system and included all the model system centers in their research. And yet, the payment system for long-term care hospitals is quite different, and so the impact might be different. Also, long-term care hospitals have a requirement for a 25-day length of stay, and so if you're looking at length of stay and you've got these two different competing issues going on within your facilities, you might be masking a true effect. In terms of the discussion, there should be obviously discussion about potential sources of bias, direction and magnitude of any potential bias. One of the challenges with Medicare data is those facilities, when there's mergers, acquisitions, their IDs change or they get merged, and so you kind of are at the mercy sometimes of not knowing that this identifier and this identifier are within the same year or actually the same place. We can take advantage of some of the historical things that are going to be happening. ICD-10, anybody? That will be really challenging, I think, for research as well as the clinicians and policymakers. I think the discussion should also speak to clinical plausibility of results, generalizability, clinical implications, and I think in inpatient rehab facilities, this is an area that we really could spend a lot more time on. What does 3 units of function really mean? I'm going to I'm running out of time, so I'm going to kind of quickly go through the next. One of the things that I've learned is that there's just so many nuances to the Medicare databases and the model system databases that I've worked with. And so one of the things that I think would be really nice to help people like me when I'm doing searches is that if everybody used the official title of the database in their abstract, so that when I do a search, everything pops up, and if somebody's done a really, really great study and they know all of the proper Medicare variables to use on stuff, I can benefit from that. So I think that would be really nice. Maybe a bit too much to ask, but. Ethics, privacy, I think there's a lot of issues related to large databases. In the Medicare data use agreements, they say if you have fewer than 11 cases in a particular cell in your research, you have to blank that out. You can't report it for privacy reasons. And I think that's probably a pretty good rule. Maybe it should be applied to other databases. Want to also speak to graphics. This is about clear presentation. Graphics can be great as a way to present information. This is actually one of my favorite articles about achieving graphical excellence. What I particularly like is they talk about the different ways data can be presented, and for example, pie charts and indication advantages and disadvantages. Want to kind of wrap up by saying that the consort group actually is working on a kind of global reporting guideline for use of what they call reporting of studies conducted using observational routinely collected data, record. And so I'm thinking that their extension of the strobe, I might be extending their extension, and maybe this should be the work that we're doing should be called the re-record, the rehabilitation research studies conducted using observational routinely collected data. Want to highlight the website, which has just been updated and is a wonderful research source to anybody, both junior, senior researchers, very friendly, lots of great stuff in here. There's a ton of reporting guidelines that are out there, so you'll see probably more and more of these in studies. There's one just focused on reliability, actually, that I'm using right now for a reliability study I'm working on. There's even more reporting guidelines. There's extensions to a lot of the reporting guidelines, so consort in particular, and there's more and more coming all the time. So just in summary, translation of research from the published literature requires that information be, the studies be designed and reported and interpreted accurately, and these reporting guidelines can help that. And so I hope that some of the things that I've been talking about today are things that you think are also important for people to report in their studies, so that the information can be used to improve care, improve policy. Want to acknowledge, again, this work is funded through Ken's R24, and I appreciate the opportunity. Wanted to wrap up with one of my favorite quotes, which is from my work in health literacy. So this is Joseph Pulitzer. Put it before them briefly so they will read it, clearly so they will appreciate it, picturesquely so they will remember it, and above all, accurately so they will be guided by its light. And I will put up my information, and